So welcome everyone. This is a third Panthera study club. My name is Ian Spray and I represent Panthera in UK, and I look after customers in parts of Europe and Asia. And we have a few other colleagues from Panthera in the call from North America, and actually many guests from North America in the call today. It's quite a big one, I think. So welcome everyone. The objective of Study Club is to, we take a topic of interest in dental sleep, and then we explore that in terms of literature, expert opinion, clinical cases, and also especially in appliance design considerations. So the topic for today is bite registration, and we're going to talk about start positions, vertical opening, bite taking techniques, and how Panthera uses bite information that you send us to design your appliances. And to be clear, this webinar is not instructing you how to take a bite reg today or where to start treatment. These are clinical decisions, but it's helpful when you understand what we do with that information and the capability on our side to make the perfect appliance for your patients. So we'll talk about that at the end. The session is interactive in a couple of ways. So first of all, at any time in the meeting, you can go to the 9 dots in the corner of the screen, and you can go to the Q&A, and you can add a question in the Q&A. And then at the end of the meeting, we'll review and discuss those. And then at that point, we can also unmute to make comments if the group isn't crazy big, and have a bit of a discussion. And in the coming week after this, I'm going to send you a feedback form. And if you want, you can also complete a short learning assessment. So when we receive those, we can send you a certificate. And this really certifies that this qualifies as an hour of CPD according to the UK General Dental Council Lifelong Learning Scheme. Please be aware the meeting's being recorded, and the recording will be shared later with other practitioners who couldn't attend. So that's the housekeeping, and I'm happy to be able to introduce our expert speaker, Ama Johal. Ama is professor and consultant orthodontist and academic lead for orthodontics at Bart on the London School of Medicine and Dentistry, Queen Mary College, University London. He's completed a PhD in the use of mandibular advancement splints in sleep breathing disorders, and he has over 100 publications in peer-reviewed journals. And his research interests include the impact of quality of life in orthodontics and the management of patients with sleep-related breathing disorders. Over to you, Ama.
Thank you, Ian. Good evening, everyone. So hopefully, as Ian said, we'll focus, I guess. I've sort of got a little bit of an introduction for those of you clearly familiar with dental sleep medicine, but just to really get a sense of the impact of our intervention, and certainly using the Panthera device, what we can actually achieve for these patients. We are going to focus on bite registration as well, and really the relationship between bite registration and what I've called optimal treatment outcomes. So I'm going to provide a little bit of an overview of sleep disorder breathing, so that we're all on the same page and we have a perception of the depth of impact this condition can have on our patients. Then we'll bring it into custom-made mandibular advancement splints. I call them mandibular advancement splints, but as you're probably all more than familiar, we can call them MADs, mandibular advancement devices, mandibular advancement appliances, but fundamentally, they all share in common the ability to advance the mandible away from its rest position. And you'll see visually the impact of that. We'll focus very briefly on mandibular advancement devices in terms of what the Panthera Classic and the X3 can offer us for our patients with sleep disorder breathing. And then perhaps more importantly, start to address this issue of mandibular titration as being really the key to our ability to get successful outcomes in our patients. And we'll look at the two devices in terms of how we can adjust these or titrate them for our patients to be comfortable, But more importantly, the sort of balancing act that has to take place sometimes when you're addressing this with patients. Bite registration can be a little bit challenging sometimes, but I'm going to provide you some clinical tips. And I'm also going to present you with a digital workflow, really, hopefully, where pretty much most of us are these days. And as Ian said, we will have hopefully a little bit of time at the end for questions, but certainly if you can put them into that icon that Ian alluded to with the 9 little dots, isn't it? So an area there where Ian can then narrate those questions back to me at the end. So let's just start by kicking off and focus on this term, sleep disorder breathing, and just explore what it is and what impact it has. So I've illustrated 2 photographs here. On the left, we've got a patient who is in the supine position and breathing quite comfortably. As you know, humans are obligatory nasal breathers. The air will pass through the nasal cavity, along the back of the soft palate, behind the tongue, epiglottis, and into the trachea, and all is well. On the far right, you can start to see that the soft palate and perhaps even the tongue are starting to impinge on the pharyngeal airway. And this tissue is somewhat unique, as we've all come to appreciate, because it is very much devoid of any skeletal architecture, which makes it incredibly prone and susceptible to collapse. So, within the spectrum of sleep-related breathing disorders, we have on the left what we sometimes term non-apneic snoring. This is the individual who essentially goes to sleep, sleeps all night, in theory, wakes up feeling reasonably refreshed, but their partner looks like death warmed up. So the non-apneic bit is essentially an apnea is a complete cessation of breathing, which lasts at least 10 seconds. So these individuals don't demonstrate this arresting of breathing. To the far right, you've got obstructive sleep apnea. And we tend to classify this internationally on the basis of the number of apneas, which I described as those complete cessation events, and the number of hypopneas, which are milder respiratory events, in which around 50% of the normal level of oxygen passes the obstruction. So we combine the number of apneas and the number of hypopneas, and we come up with an index known as the apnea-hypopnea index, the AHI. And if you have an AHI per hour of sleep, I might emphasize, between 5 and 15, you're classed as having mild obstructive sleep apnea. You can see if that's greater than 30 events an hour, then that's quite severe. And naturally, we're always going to have what's known as a grey area in the middle, where patients go to sleep, they snore, and they'll have occasional apneas and hypopneas. To illustrate this in terms of airflow, if you just observe the picture at the bottom now, to the left of our scheme, we've got normal airflow, where you can see there's going to be pretty much 100% oxygen saturation within our patients. We normally have an oxygen saturation of around 96 to 100%. Flow limitation starts with snoring. As you can see, there's an interruption in the passage of air through to the far right, where the patient's having an apneic attack and almost flatlining. They're having a complete episode of suffocation. And this is what we're talking about this evening, essentially managing this end of the spectrum confidently and comfortably. So simple, it's an interesting term, simple, because there's nothing simple about snoring, actually. Most of us begin to appreciate that it is a loud, disruptive snoring. And based on the spectrum, what I've just illustrated, a patient could have up to 4 episodes of apnea and hypopnea per hour of sleep and still be classed as normal. So this can still be quite disruptive, not only to the sleeping partner, but have a negative impact on their quality of life, and also somewhat antisocial for these patients. Traveling, for example, can be a very big challenge. But emerging research almost seems to imply that the sleeping partner, for example, in this illustration with the hands over ears, because her sleep is so interrupted, could become very vulnerable, like our sleep apnea patients, because their sleep is so disturbed. And often we know that about 70 to 80% of these patients, these partners, avoid sleeping in the same room and sometimes even the same floor. At the other end of that spectrum, I talked about the obstructive sleep apnea. Now, this is an overnight polysomnography reading, and you can see on the left the number of indices we're measuring, but essentially it measures an awful lot of things. Brain activity is what's represented at the top of the screen, where you can see the words arousal. If you look towards the bottom end of the screen, we're looking at snoring, airflow, and abdominal and thoracic chest movements. And what you'll notice is I've annotated the word no breathing. This is where the patient's flatlining, having an apneic attack. Then if you look up in terms of what the brain does at this point, it actually wakes this individual what's called a microarousal. In other words, it tells the individual you need to start to breathe because we are suffocating. And you can see correspondingly, if you come back to the lower half of the screen, there's a lot of chest wall movement, a lot of abdominal wall movement, and the oxygen saturations are in fact seen to increase momentarily until the patient then has another apneic attack and consequently another microarousal. And this whole process proceeds and repeats all night long for these sufferers, such that we now begin to understand why there's such a negative impact of sleep apnea. Invariably, these patients are going to have a very poor quality of sleep because of those multiple microarousals. So whilst their head has been on the pillow for 6 to 8 hours, they've actually had very little real sleep. They're going to be obstructing either with a combination of apneas and hypopneas over the course of that night. Consequently, these patients have excessive daytime sleepiness, and we often measure this using a variety of scales. But ultimately, most of us can relate to the impact of a deprived night's sleep and the inability to concentrate. Neurocognitive impairment takes place. And in addition, and not surprisingly, these patients often get mood disturbances and depression, all primarily due to this oxygen deprivation. And there's a lot of comorbidity, which is a great shame because we can address this condition quite confidently within the specialty of dentistry. And there are cardiovascular, metabolic issues, and certainly stroke has been associated with untreated obstructive sleep apnea. So now I've painted the picture as to why we should be involved. How do we get involved? And essentially, where our role is to fundamentally obtain the appropriate level of training. Once we've got that training, we can provide these patients with custom-made devices. And the question often arises, how do they actually work? Why is it that we as dental professionals can change the quality of life and impact for these patients? Well, the commonest reported modality of action is to increase pharyngeal airway space. And what you're looking at here is an image. It's a three-dimensional fluoroscopic image of this patient in the supine position. And what I've drawn for you on this image is a line which represents the posterior pharyngeal wall, the soft palate, the epiglottis at the base, and the shadow of the tongue. And this individual's lying on their back in the supine position, and you can see pretty much in occlusion. Now, when we put an oral appliance in situ, as you can see now, there's quite a significant increase in the size of the posterior pharyngeal airway space. And it's also illustrated by the two images to the bottom of the screen, which are drug-induced sedation endoscopy, showing from the first image to the far right, where the tongue is now advanced and the epiglottis you can actually see, in fact, you can almost see to the larynx. So this would have an incredibly positive impact on this sleep-related breathing disorder. But in addition, what I'd love you to do is think about this pharyngeal airway as this collapsible tissue. I often describe it as a party balloon, very susceptible to collapse. And if you were to hold each end of this party balloon and put it under a slight amount of tension, naturally its ability to collapse would be reduced. And when we put an oral appliance into someone and advance that mandible, we're basically introducing stretch across that whole pharyngeal airway space, thereby reducing its propensity to collapse. And finally, some emerging research, some of which we undertook back in 2006, which is a slightly frightening thought for me because that's 2 decades ago, we demonstrated that actually wearing an oral appliance, in fact, stimulates some of the upper airway dilatory muscles. And those of you who are actively interested in this field are probably more than aware nowadays we offer hypoglossal nerve stimulation techniques. So that is a recap of how these devices work. In terms of what are we achieving with treatment, for sleep apnea patients, we essentially are looking to try and resolve the clinical signs and symptoms, i.e. that excessive daytime sleepiness, improve their neurocognitive functions, address that comorbidity. But in addition, we're also looking to normalize the sleep physiology in terms of their apnea-hypopnea index and in terms of their oxygen saturations. And we are more than capable of normalizing and resolving all of these symptoms within the specialty. So when it comes to clinical evidence and it comes to actual effectiveness of treatment, fundamentally, there are 2 recognized non-surgical interventions. To the left is CPAP, continuous positive airways pressure, which fundamentally is going to bed with essentially a mask strapped to your face, which works a little bit like a Hoover, but in reverse. It takes air, it filters it, and then it forces it into the airway, expanding the pharyngeal airway. Now, you can hopefully relate to this very well, because if you think back to your party balloon scenario, if you were to inflate a party balloon, well, by nature, it can't collapse. That's what CPAP does. The challenge we're confronted with CPAP is, whilst it is highly efficacious, i.e. very effective treatment, patient adherence is pretty appalling. As low as 1/3 of the patients that should be using this actually can cope with it. Therefore, their alternative, and often only recognized alternative, is mandibular advancement splints. Here, the argument is that adherence, as I will illustrate to you, is much better. Patients much prefer this, a strong evidence base in favor of, but the efficacy hour on hour is lower than it is with CPAP. So there is the dilemma. However, we have a treatment for patients which they prefer to use, and they do use for more hours than they use CPAP. So we're in a very influential position. And here is some of that emerging evidence. If you look at adherence, what we find on average, patients will tolerate the oral appliance for a minimum at least 1 hour more. More often than not, we find that patients tolerate CPAP for 2 to 3 hours per night, whereas they'll wear their oral appliance for 6 to 8 hours a night. Indeed, the other thing to think about is preference. Both of these treatments are choice treatments. We can't force the patient to use them, but what we know is that patients much rather prefer to have a mandibular advancement splint. I mentioned the risk of excessive daytime sleepiness, and what we've come to learn again from all the published literature is there is highly effective treatment in CPAP and mandibular advancement devices, as it's referred to in this drawing, but ultimately there is no difference between the two treatments. They're both effective in reducing a patient's liability to fall asleep. ESS, apologies, represents the Epworth Sleepiness Scale, which is a validated scale used subjectively to assess a patient's sleepiness. What about quality of life? And so we've used functional outcomes of sleep, the FOSQ. And interestingly, both treatments, CPAP and oral appliances, improve the quality of sleep. And again, there's no observed difference between the two treatment modalities, all of which is making for excellent reading for us. And then comes the interesting one in terms of diastolic and systolic blood pressures. We know that these patients, when they suffer oxygen deprivation at night, hypoxia, the heart reacts by pumping to try and get blood around the system, but which is lacking in a quantity. Therefore, these patients often have exacerbated diastolic and systolic blood pressures. What's very fascinating is that both treatment modalities, CPAP and mandibular advancement splints, reduce this nocturnal blood pressure, with no difference being observed between the treatment modalities. And I want to share this with you because I thought this is rather interesting. This is from last month. This is a patient of mine who has quite severe sleep apnea, was intolerant of CPAP, and I provided her with a custom-made mandibular advancement splint, the Panthera Classic. And you can see what she says. It's a complete game changer. I have so much energy. I no longer snore. It means a lot to my husband. And I find going out and about more because she has this extra energy. And she describes it as a new best friend. and this is just a taste of the feedback that I'm sure myself and yourselves involved in this world experience on a fairly regular basis. So the question now comes, why titrate mandibular advancement? In other words, we know that patients can protrude their mandible a variable amount from patient to patient. Therefore, why is there a need to think about progressively bringing that mandible forward? Well, we know that typically protrusion is necessary for effectiveness, and that the more protrusion you get, the greater the reduction in respiratory events. Those apneas and hypopneas all start to diminish, and I'll show you some more evidence in a moment. Studies also show, though, what we're having to think about is that the more we protrude the mandible, the greater the likelihood of side effects, and in particular, because the force in the mandible is transmitted towards the teeth, we get these unwanted effects of the dentition changing, which is something that none of us want to see, but we accept is a byproduct or a side effect of treatment. Therefore, our goal has to be to try and limit this from happening. So the discussion really, and it is a contentious issue, is where do we start with the mandibular advancement point in terms of protrusion? And you can vary from anything from a 0 to up to 75% of what we might call comfortable maximum protrusion. The definition of protrusion is fundamentally the distance between what a patient can confidently or repeatedly achieves in retruded contact position to their most protruded position. Now, this is not a position of treatment choice because that would be a rather uncomfortable position. So there is a clear difference between what a patient can comfortably advance their mandible to versus what they can confidently or maximally protrude to. And we never want to go to the latter. We could consider going to maximum comfortable protrusion. And again, I'm going to elaborate on this in just a moment. Now, I put this in for you, not that I'm trying to scare you, but I'd like you to think just for a moment. If you have a patient with an incredibly deep overbite, such as a class 2, division 2, for these patients, the vertical opening that's often required in order to provide them with a customized mandibular advancement splint is quite a big deal because they're often overclosed, these patients. So opening the mandible is a difficulty for them. Then to protrude the mandible would make these appliances highly uncomfortable and therefore potentially compromise adherence. So I think we need to be conscious of the presenting bite that we're dealing with when we're looking at the amount of protrusion that we might progressively introduce. Now I want to show you why it is important that we do titrate forward and we don't just assume a figure out of midair, let's say. And this study by Cato really was a fantastic study in terms of demonstrating that much like we do with CPAP, where we titrate the amount of pressure the mask delivers to the airway to keep it patent, we have the same capabilities within mandibular advancement devices. So this patient is in what we would call a relatively retruded contact position, except the bite is open in order for us to construct a Panthera Classic or X3. To the right, what you're looking at is oxygen saturations in this patient, and you can see the black lines are pretty profuse, and this individual has severe sleep apnea with oxygen dips up to 50%, which is horrendous. If we advance by 2 millimeters that mandible, what we start to see is a very negligible improvement in the oxygen saturations. If we come forward 4 millimeters, we start to see a more significant impact on the oxygen saturations. And if we dare go to 6 millimeters, we've practically eliminated or normalized this patient's oxygen saturations and therefore, by definition, their quality of sleep. So hopefully this illustrates to you the importance of why we need to titrate forward. So what is this optimum finishing position? Can we predict effective treatment positions for all our patients? Well, the simple answer to this is no, we can't. And this was quite an interesting study where they looked at efficacious protrusion, i.e. how much protrusion versus mild, moderate and severe disease. And you'll notice on the graph there to the top right, I've drawn a little box, and the little triangles represent moderate and severe disease. And what you're noticing is that we're progressively having to advance more in this type of patient, because with a patient with moderate to severe sleep apnea, clearly that airway is so collapsed that you need to advance the mandible in order to literally open the pharyngeal space in such a significant amount that the oxygen saturation start to normalize. And in these patients, what they found was anything up to 38 to 100%. The point I'm trying to make really is that there is a significant amount of patient-to-patient variation. Hence the need for a customized device, which is what we're offering and talking about this evening. And secondly, the need to titrate to your specific patient's needs. Half the patients were treated with less than 70% of maximum protrusion. Now, that doesn't surprise me and shouldn't surprise you, because patients with severe sleep apnea, fortunately, are less common. Therefore, we're probably predominantly dealing with patients with either no sleep apnea, i.e. non-apneic snorers, mild or moderate OSAs. So now we come back to the golden question. Where do we start with our protrusion? And I've described this as a balancing equation. The things that are going through your mind that you should consider are firstly patient comfort. We know that if we maximally advance the mandible, the likelihood of us getting success in terms of controlling the oxygen saturation is incredibly high. But equally, these are humans at the other end that are receiving these devices. And if we advance the mandible and make it so uncomfortable for them, their rate of dropout is going to exponentially rise. We want optimal adherence. So my philosophy, I'll share with you after Ian spoke to you and shortly, but it's a slightly different approach. I worry, like all of us, about the side effects. In an ideal world, we don't want side effects, but we have to accept that they do come with this treatment modality. Therefore, our goal should be to minimize as far as possible. One of the controversies or one of the difficulties we as clinicians face is that with the time to effectiveness. With CPAP, it's an instant effect. You turn the pressure on, it's there immediately, and the patient's sleep is significantly improved. With an all appliance, the more you titrate, the longer it's going to take you to get to the point of effectiveness. So this is what you're constantly balancing. Do I make the device as effective as possible, but risk compromising the patient, long-term wear or dropout risk, or do I give them an approach which allows them to adapt gradually, but accepting that the improvement will be slower? And equally, it depends on the system that you're using, i.e. the type of device. And we're focusing this evening on two appliances, both of which offer the capacity for titration. And I would implore you to say that we should maximally use the advantages that these appliances offer us. So one of them is the classic. And here we have what we describe as a large out-of-the-box titration range. And by a large range, we're talking 9.5 millimeters. The beauty of this is that each increment is taken in 0.5 of a millimeter. And my logic here is that every patient can tolerate 0.5 millimeter. And so gradually what we tend to do with these patients is start them at a point that we agree at, which we'll come back to. But from that point forward, as their symptoms resolve on a weekly basis, we review their progress. If the symptoms persist, we shorten the arms and we advance them another 0.5 millimeter. Similar capabilities exist within the Panthera X3, except the titration method, is slightly different. You can see there are these little arms that literally pull out and you just change them over. And again, they increase in the same 0.5 millimeters. With this appliance, you have slightly less titration range, 6 millimeters, which I might add is quite a significant amount of titration, to be fair. So you could consider, if you were prescribing this, you might incorporate a little bit of protrusion at the beginning. But as I said, we'll come back to this. Hand in hand with protrusion, as all of us appreciate, the mandible is like a hinge. You cannot advance the mandible without opening it. And the question is, what is the optimal vertical dimension? VDO, as we're going to refer to it. I don't like acronyms, but there are a lot of them in sleep medicine. A study in 2012 using drug-induced sedation endoscopy showed that vertical opening can potentially lead to airway collapsibility. And I'm going to illustrate this to you pictorially. If that were to happen, if we were to increase the vertical dimension too much, then obviously our appliances are going to become much less effective. So we need to think about that as well. So it's a slightly more complicated balancing act. This systematic review and more recently undertaken in 23 showed that the evidence was variable, and you can see why. It's the typical scenario. There's a lack of RCTs that meet certain criteria. The vertical dimension increase within these studies varied from 1 to 5 millimeters. It's very hard as us clinicians to try and relate to some of this published research. So I'm going to try and give you some guidelines. I would recommend for those of you who are interested to read this paper by Gao et al., which is almost 2 decades old. I think it's published in 2004. It's a great article because what the authors attempted to do, and I think did very well, using MRI, they looked at the changes in cross-sectional area in the upper airway with advancement and opening. And specifically, what they did was, in the first 4 positions, you'll notice that it is F, which stands forward, is 0, then 50% of maximum protrusion, then 75%, and then 100% of maximum protrusion. And the vertical V stands for vertical. In the first 4 scenarios, they introduced no vertical opening. And then if you look to the right in the figure, you can see, so you see 1, 2, 3, 4 are all in a linear AP plane. 5, 6, and 7 incorporate an element of vertical increase from 50% to 75 up to 100. And they showed that basically what we've all come to appreciate is that if the mandible is advanced in a forwards to backwards direction, i.e. forwards, AP, from 1 to 4, there is a significant increase in the pharyngeal airway dimensions. However, if you introduce the vertical, the 5, the 6, and the 7 into that equation too much, then you start to compromise the outcome on the airway, and it is variable. Now, I'm going to illustrate, I said I would illustrate this to you. So what you're looking at here is a lateral fluoroscopic image of a patient who's in normal occlusion, and it's a class 3 occlusion with lateral open bites. The image to the lower left here illustrates that if the mandible is translated in the forwards direction, incorporating very little vertical opening, you can see a huge increase in the postpalatal and postlingual airway space represented by the yellow lines. However, if this patient was to swing their mandible too far open, or we were to inadvertently hugely increase the vertical dimension, what actually happens is that we start to constrict the posterior pharyngeal airway. So hopefully, visually, you can see that the mandible is this hinge. And if you incorporate too much vertical opening, you can compromise the AP change that you're trying to achieve. So this is our goal as well. So we're constantly thinking about the amount of AP change and minimizing our vertical parameters. So, as I said, we're aiming to reduce that vertical dimension. Appliances, by their very nature, have to sit between the teeth, and therefore there is going to be a degree of natural vertical opening that is associated with all custom-made devices. However, with the Panthera, we can limit this vertical opening quite considerably if you were to consider the addition of some hooks anteriorly and some use of elastics. This would hugely increase the effectiveness, I believe, and minimize the increased vertical dimension risk. So we know that patients do need some vertical opening because otherwise they tend to get this suffocating event. So yet again, we refer to this balancing act. So it is also important for us to understand that part of the process of recording your bite and scans or registration for a Panthera Classic or an X3 requires a registration bite. So I'm going to hand over to Ian, who's going to give you an overview of how Panthera actually use the bite that we provide to them before I demonstrate how I do this. Thank you, Ian.
Great, thank you, Ama. Yeah, and just to repeat that, you know, we're not prescriptive about telling you what method to use for taking the bite registration or where to start treatment in terms of the amount of protrusion of the starting position. But there are ways to optimize the information that you provide to us. And so typically, most dentists are sending us a bite in a desired starting position, which is open and protruded to some extent. And the ideal opening in that bite for us would be 3 millimeters at the narrowest point, which is typically posteriorly. And basically, this is because in a case of with regular occlusion, this is going to be the amount of space that's taken up with the appliance, and it means we don't have to make any adjustment to the vertical dimension to insert the appliance effectively. This can then become slightly more complicated in some cases. So in this example, you'll see this mandibular curve at the back in the occlusion. So when the dentist is taking this bite registration with a fork in the front, this looks like a very nice amount of vertical clearance in the bite registration, and it's probably not obvious that this lower molar is encroaching so much. And from our point of view, with this bite, obviously to insert an appliance, we need to open this bite considerably to have the lower splint covering at least part of the last molar on the lower arch, because we're trying to cover that tooth in a way that prevents over eruption, ideally, although it's always an option for you to prescribe this as being uncovered in the appliance, and that's your clinical decision. But to do this, to open this bite, we're using our virtual articulator software, which is software that we've created. All of our design software is proprietary and created by Panthera to do the things that we want to be able to do, and this gives us a lot of freedom to be able to adjust bites and optimize that for the patient. But all kind of articulation is done based on average patient value. So when we open these bites, the more we have to do it, potentially the less accurately it represents your particular patient in the chair. So in those kind of cases, if you can give us a bite in maximum protrusion with that kind of natural clearance, 3 millimeters perhaps posteriorly naturally with that patient, then this is more likely to be accurate for that particular patient. It's more likely to minimize the opening, and you can also reflect the patient's natural lateral deviation in the maximum position as well, which is, it's not so critical for us because we can adjust our appliances independently left and right, so we can follow a deviation, or you can follow a deviation by titrating one side differently to the other. Now, when you do this, give us a maximum bite. Of course, we're not starting treatment in a maximum position. This is potentially uncomfortable and a problem for the patient. So you can also tell us where you want the starting position to be in relation to that maximum position. You can tell us the number of millimeters to come back from there to start the treatment. And if you don't tell us any measurement, we will by default bring it back 4 millimeters. So in an average patient, this is about 60% of their range. But you can make this decision. So just to recap, those first two options are the two options that we recommend, either giving us a bite in the starting position, or the starting position is the recorded bite. The second option is maximum protrusion, which we will start 4 millimeters back from there unless you give us another measurement. And then the final option, which we're not encouraging this by any means, but so that you know that this is possible. You know, sometimes you might not be able to get a patient back. You might not be able to take a bite in a protruded open position for some reason, but you might have a centric bite. And we have this capability to open and protrude in our software from this position. And this is, you know, this requires the most kind of artificial manipulation, but it works perfectly well in most cases. And all we need to do this is to have a measurement from a position that we can identify. So for example, from centric, if you tell us to open and protrude 3 millimeters for a starting position, then we can do that in the software. And or we can do this in terms of distance from edge to edge, because we can also identify that. And this is in some ways convenient or easy if there's a problem with taking a protruded bite, but you just have to bear in mind that this is not representing the exact movement and anatomy for that patient. So you can make that decision on that basis.
Thank you, Ian. So guys, here are my clinical tips to how you can make a digital workflow work. And as Ian said, I couldn't agree 100% more that the less guesstimation that's going into the construction of these devices, because they are, you know, let's face it, they're high value treatments. We want to get these right first time. We don't want to have to refit them or present ourselves with challenges in the chair. So my literal ideology is keep it simple. And in doing so, I'm going to share with you what I'm going to recommend that you might choose to go down this route. Whether you use impressions or scans, it really doesn't matter. But digital workflow makes life so much easier for all of us, and in fact, communication with Panthera Direct. So we're going to talk about bite registration, and Ian's alluded to the fact that in an ideal world, we want at least that 3 millimeters of clearance and take away the guesstimation. I put postured bite in brackets, but I'm going to come back to that in just a moment. So I've made a little series of videos, which hopefully you may find helpful. Now, what I'm going to introduce you to is this D gauge, which is not available widely, but Ian is more than happy to supply with this. But what I'm going to illustrate to you is this little gauge here, this D gauge, sorry, has, in the close-up, you can see it's about 4 millimeters anteriorly. So there's no element of protrusion that's necessary at this point. This is to help you clear that posterior dentition and give Panthera the adequate amount of posterior occlusion clearance that we require. So I'm going to show you how this works. What I've done here with this patient, who very kindly volunteered herself, I'm illustrating to you in very two static images what centric relation represents. And you can see this, you can see the video in a moment, but there's an overjet of about 3 millimeters. Now, for your own peace of mind, it's a very easy maneuver to ask this patient to maximally advance. And you can see this patient's coming up to like 8 millimeters. So there is an inevitable, as Ian alluded to, almost 11 millimeters of protrusion capability within this patient. Now, that isn't unique to all patients. As I illustrated earlier, with class 2 division 2s, they'll barely achieve a few millimeters forward before they start to complain that it's uncomfortable. And we have to remember, behind these teeth is an adult, and they don't tolerate change too well. So I'm going to show you now an image, a digital scan, and just some of the key criteria that we want. These are very short, so I will go quiet for a moment. Okay, so we've just done a scan of the upper and lower teeth. You just need to ensure that you have a little bit of soft tissue margin showing all the way around. And you don't need a full palate, obviously, for the design. Perfect. So having scanned the top jaw and the lower jaw, this is the static occlusion for this patient. So you remember she demonstrated almost a 3 millimeter overjet. So we've got some, you know, good images. And what we're going to do now is I'm going to show you putting the D gauge, the D guide in and the bite fork, and what kind of features you should be looking for when you place this. So we're just going to show you what normal centric occlusion is like in this patient. So just bank over for me. Perfect. And with the patient occlusion, roughly, if I hold the ruler this way, you get a better idea, but we're talking about maybe 3 millimeters of overjet. Now, what I want to do is I'm going to pop in the bite fork, and this has about a 4 millimeter opening at the front. Just bite carefully, please. That's lovely. So you can see the immediate effect of the opening at the front, but more importantly, down the back, you can see we have comfortably 3 millimeters of clearance between the posterior teeth. Also, the fit of the gauge is perfect for this patient. One last thing to note is that as this gauge has gone in and the patient is biting on it, the overjet has slightly increased. In other words, it's encouraging the lower jaw to rotate slightly downwards and backwards. So I'm now going to show you how, having tried this, the D-guide bite fork, how we use this occlusal registration material to really record the bite in zero time, really. So this gauge, as I illustrated, the patient is biting quite confidently and comfortably into this position here. So there's no protrusion in this. It's just simply an opening. So we just need to place enough of this at the posterior end to record our space and occlusion. So I'm just going to add a little bit of top and bottom ends. And then I'm just going to flip it over and add again on this side. Lovely. And now we're going to just record the occlusion with that bite gauge in place. Wonderful. So you can see the material is just sufficiently covering. We don't want too much excess, ideally. And the reason you don't want too much excess coming from the buccal is that ultimately the scanner won't be able to detect the bite registration. So now I'm going to show you the actual process of bite registration with that in place. Okay, so we're just going to record the bite now. And you heard the little click, and that will generate an image which looks something like this. And then when you clean the image, compress and obviously get it ready for sending, you end up with something like. So then you can see with the bite fork in, the registration, the bite has been recorded, and you can see we've got more than adequate clearance here, which is perfect. We've got sufficient soft tissue demonstrated so that we'll get hopefully a very good fitting appliance. Fantastic. And more often than not, you'll notice sometimes the bite is just reduced a little bit. So off this bite now, I will ask the designers, Panthera, to make a forward protrusion of about 1 to 2 millimeters is more than adequate start. So now let me illustrate to you why I just said the latter statement. Okay, so we're just going to... Oops, here we go. So I demonstrated to you in this patient, in normal centric occlusion, there was an overjet of about 3 millimeters. So all I've done is taken a superimposition curve for you, a scan of the upper and lower arches, just to illustrate this point nicely. As I put the bite fork in, I've naturally encouraged the mandible to rotate slightly downwards and backwards, and I've actually generated an overjet of about 5 millimeters. So it's gone down and backwards 2 millimeters. So if you were to then fit this device in this bite, what you would find is that its effectiveness would be compromised to some extent, and the patient would almost definitely need to start advancing with those 0.5 millimeter increments. So to get around this issue and to provide the patient with something that's A, going to be very comfortable, and B, not prove to be ineffective, but rather start to be effective, all I would say is that when you take the bite, you ask the Panthera design team to advance the mandible 2 millimeters from the registered bite. And what you can see is all I've done literally is recreated the overjet that we had, but with the bite opening, thereby keeping life very, very simple. You don't need to do any complicated mathematics here by working out the maximum and then extracting from that or fearing that you may not have recorded it. All you do, you put the bite fork in, it'll give you your occlusal clearance, tick box 1, you've taken the variability out of the equation. And now to keep your effectiveness to the max that you can at this point and encourage maximum comfort for the patient, just ask for a 2 millimeter advancement. I hope you find that helpful. I think that pretty much brings me to an end. So, and that's Ian's contact details. Thank you.
Just to add there, thank you, Ama. That's great. So the D-guide bite fork that was demonstrated there is it's a kind of prototype fork. Really, we've got 2 versions that we're testing with customers. This is not a highly sophisticated piece of equipment, but it helps you stabilize the bite and get the right kind of vertical. And so far we're providing samples if you want to try it. I guess probably everybody on this call has another existing method of doing this, and Amma, I think you use other methods when you're doing this in your practice historically. What have you done in the past? You've used different tools.
Yeah, I mean, I still do. I use wax only because, being an orthodontist, I'm so familiar with recording functional occlusion bites for, a variety of appliances, functional appliances, for example, that I'm quite comfortable and confident. But equally, I appreciate that if you're not that familiar with that technique, then it's a lot of faff and a lot of extra effort and work, and a degree of guesstimation is involved, or confidence, let's say. So I find that this gauge may actually help clinicians in that, it gives them that predictable clearance, and like you said, it takes away that variability that we're putting pressure on Panthera as a manufacturer to produce this high item value that's going to instantly fit and be comfortable.
Yeah, and I guess you've already raised this point about adjustability as well, but we don't need to start the start position too far forward because we have a lot of adjustability in the appliances. So I think in the past you've been quite conservative, I think, in your approach to a starting point, haven't you?
Yeah, and again, it just reiterate, very, very much I'm determined to some extent by the symptoms. So if I'm treating somebody who's got simple, let's say simple non-apneic snoring, you can no episodes of witnessed apnea or hypopnea, then the probability of having to advance that mandible forward is very, very low, because you're trying to minimize the vibratory effect of in the pharyngeal airway. Whereas somebody with moderate to severe sleep apnea, we're all going to accept that they're going to need that protrusion. So we can't treat everyone the same, which is why, as you rightly say, predominantly I've always been more conservative. But equally, I think I've benefited from getting better adherence.
Yeah. I just want to open this up, really. If anybody has any questions, you can either put those in the Q&A or unmute to ask a question. And while you're thinking about that, I'll also just say to Daniel, who is our technical expert in Quebec, if he has any thoughts or comments from what we presented there.
Yeah, thank you, Ian. No, actually, I love the presentation about the bite. Mostly, the two first options, we'll say it that way, the desired starting position and the maximum protrusive bite. My perspective, of course, is a mechanical perspective, more so that when we receive the scans here in-house and we receive the data, then we go to fabrication. So what gives us an easier workflow and also a more, I think, comfortable and precise device is the maximum protrusive bite is sometimes presented as something important, but for me, it's mostly to know and record exactly how the patient advances, the natural movements of the patient. Advances, protrudes, and opens is basically what it tells us. So it's like if we're watching a movie from backwards, because what we're going to do is we're going to take that maximum position and reduce and then start moving forward. But we have recorded, or you have recorded, the exact movements if there's any lateral shifts. So we're able to respect those movements, those patients' movements, without forcing them back in an unnatural way. It's my answer to this is, again, mechanical, based on the cases that we've made or that we've maybe had to remake, maybe because the bite registration wasn't accurate enough at the time of the taking. But the chair side evaluation is so fundamental, and in recording those multiple positions. Some doctors are adamant in starting to a certain specific position, and then at that point, I will always suggest maybe registering a maximum protrusive bite, but also going and giving us the desired starting position. So you're dictating the treatment plan. At least we will have both situations where we're able to adjust and adapt based on the morphology and the dentition. So that would be my most important input in all of this this presentation.
Great, Daniel, thank you. So we have a couple of questions in the Q&A. The first one is to clarify, we do not need to figure out max protrusion and then take bite at 60% if we just use the D guide. So I'll take that one, because the D guide is really a very simple fork that we provide for dentists if they don't have an existing method of doing this, and it's just another option, another tool. Technically, we're not even selling this fork yet. We've just started to make this as a helping tool for people who needed it. But we can provide some samples if you don't have an existing method. And 60%, I guess, is one of many theoretical starting positions. And there are different theories about what percentage is correct for starting. We're just saying that if you give us a bite in maximum, and you don't tell us where to start, then by default we start 4 mil back from there, which is approximately 60% depending on the protrusive range. But this is, we're not saying that this is the correct place, but we think it's likely to be a good place to start, considering that in the appliance you can also adjust forward and back in fine increments if that's not the right place on day one. You know, you've got a lot of options to adjust that straight away. The other question is for you, Ama. Have you ever had a patient where you fitted a device and it made their snoring or symptoms worse? Is this simply because we've not recorded enough protrusion, not recorded a protrusive enough starting position, and therefore the insertion of the device has encroached on the airway space?
That's an excellent question. So, as an academic, one of the things I hate to say, but I am going to say it, in my clinical experience and in all the trials that I've ever taken, I've always adopted the approach I've just shared with you all. And the short answer to that question is no, I haven't encompassed a situation where a patient has reported their symptoms have got worse. What a patient might say to me is that their symptoms haven't notably improved. And that I manage from day one. When I fit these appliances, I tell my patients that, look, they've paid for something that has this innate ability for us to adjust it, and that enhances their comfort and their tolerance and their adaptability. Therefore, the price that they pay is that the progression is slow, but the outcome will be the same. However, we'll get there to a truly effective point and mitigate that risk of unwanted tooth movements.
I think I know who asked that question, potentially, because we had a case in the UK this last week where the patient's snoring was worse in the first week or two after wearing the appliance in the starting position. But I think, well, in that situation, you just have to slowly start to advance and give the patient some confidence. I think that this is going to have a result, but they have to hang in there, right?
Yeah, I think that's crucially important, and I wouldn't make light of this. Even if I give a patient a minimally advanced mandible, that device is going to be somewhat uncomfortable, and patients immediately associate the fact that they're putting this in there. They think they're giving something. Obviously, they're putting something into their mouth and they expect an outcome. And that's why I think as clinicians, we've all learned wisely that to forewarn patients and to prepare them mentally for A, the device, and B, the impact. So one of the things I always say to them is, please just remind your partner not to expect a miraculous outcome in the next week or two. It's going to take us perhaps a month, maybe 6 weeks to get to that point, but we will get there, and we'll get there in such a fashion that you will have adapted to that change progressively as well.
Great, thank you, Ama. So there are no more questions in the Q&A, and I think we will wrap it up there if nobody else wants to unmute and say anything else.
And of course, Ian, they're always welcome to email you on that email address should they have any questions, but not want to ask them right now. So we'll be happy to take them.
Yes, absolutely. And actually, there is one more question here from New York, asking if they should deal with Europe. And no, you can deal with our reps on the East Coast there, and we can put you in touch with them. So we'll follow up with you for that.
Thank you.
Great. Thank you so much, everyone. See you on the next one.